I'm Spencer King here at EuroPCR 2017. We've been working with young operators, young practitioners of interventional cardiology, and I'm joined today by two of my colleagues, Salvatore Bugaletta from Barcelona and Ahmad Ghamaaz from London, and we want to talk about cardiogenic shock. Ahmad, tell me how you know you're receiving a patient with cardiogenic shock if you get a phone call in the middle of the night.
We try and divide this into two areas. One is what happens before the patient arrives to your lab, and then the other bit's when the patient actually gets to you. When we receive a call, we try and, as much as possible, identify many signs or many information, as much information as possible, so that this allows us to have a picture of how the patient is doing in the ambulance, or even if it was outpatient cardiac arrest or out of hospital cardiac arrest. So we go through a checklist to identify the information that we have, of course the patient's name, the age, any past medical history, if there is an ECG has been taking, what it is, the blood pressure, if the patient is looking unwell, gray, clammy, is he saturating well on his own, is he able to breathe or not, if his GCS is clear or not. All the information that is possible before they arrive, and we use this information so that we are prepared with the team in the cath lab or in A&E, whatever the patient arrives first, so that we are prepared with the right team, whether there's a need.
Because you will make a distinction from the routine STEMI patient, where you have to make certain preparations, and one who may be hemodynamically very unstable in shock.
In a normal STEMI patient, they will come straight to the lab with just a cardiologist and the nursing team. We do not prepare any other team around. If the patient is a cardiogenic shock, you will need more support. You can't be on your own. You need anesthetists, you might need surgeons, you might need a bigger team to be able to stabilize the patient.
Let's talk about this, what to do once that patient shows up. Salvatore, how do you stabilize a patient, or do you stabilize a patient before to the cath lab?
Yeah, sure. So first of all, we have to stabilize the patient because he has to afford a coronary angiography and maybe a PCI. So we cannot, survive with the patient with a low blood pressure, heart rate. So we need to start as soon as possible. Inotropic drugs like, for example, dobutamine, dopamine, and we have, to think if, for example, the patient should be intubated before the procedure in order to stabilize him hemodynamically. Also, we have to think about the electric stability of the patient. If, for example, the patient has repeatedly tachycardia, ventricular tachycardia, or ventricular fibrillation, so we have to start also some anti-arrhythmic drugs in order to stabilize it. And once we have done this pharmacological stabilization, so we have to think which is the cause of the cardiogenic shock. If we think that it is a mechanical cause, so for example a ventricular septal rupture or a mitral insufficiency, so we have to perform an echo, we have to auscultate the patient with our stethoscope. Otherwise, if we think...
So you've got to rule out if they need urgent surgery or something, but let's say you've come down to the fact that this is purely an ischemic, severe LV dysfunction you got to deal with. Do you jump straight to, there's always a question, do you jump straight to opening the artery, or do you provide some support?
Yeah, my view is that, if you think that it's an acute MI, so there is no way that, you have to open the artery, because otherwise you are not going out from the cardiogenic shock. So what we can do is actually, first of all, to see the angiography, which is the coronary situation, and then reopen the artery if that is the cause of the cardiogenic shock, and then think a little bit about some non-pharmacological device that we can use, like, for example, balloon pump, which is actually available for everyone, or maybe thereafter the procedure, so we can think about something more difficult, like, for example, ECMO, tandem heart, some supporting device. But these will be a later stage.
What do you use in Barcelona? What do you use?
So in our center, we use intra-aortic balloon pump. So after reopening the vessel, because that it makes sense. And if the patient leaves the cath lab with the cardiogenic shock, so we contact the surgeon and we start arranging all the things to make some ECMO and to prolong as soon as possible, the life of the patient.
So Ahmad, if you get the patient through, get the artery open, things are still not doing so well. how do you manage the patient? How do you try to recover the patient?
So that now shifts the treatment strategy from establishing flow in the artery to supporting a damaged myocardium and allowing it time to heal. And this is where the role of a good intensivist and a good team to support the hemodynamics of the patient and allow recovery if there is chance for that. We're lucky we have access to an excellent ECMO surgeon who has a brilliant team. And it is really a team effort. It's not, it's a perfusionist, the anesthetist and the surgeon and the cardiologist together to make that support as best as possible to provide the best possible recovery for the myocardium. So if the initial measures of opening the artery, getting a balloon pump in, that doesn't work, I think ECMO is, if you have access to ECMO, is probably the best ideal sort of next step to try and sort of buy time for allow the
So
myocardium.
these are patients clearly that are the worst prognosis we have, depending on many factors, maybe from 20% mortality up to 70, 80% mortality. But if we can intervene, we also have the greatest opportunity to save a life. So I think the take-home message for me is there are no patients with cardiogenic shock who are viable. I mean, maybe the patient is 100 years old and has terminal cancer, but short of this, you know, we have to, as doctors, try to intervene. The technologies you described, the stabilization, the support, be it with mechanical various supports, which, as you pointed out, are the only things that are really going to support the left ventricle. There are no drugs that are going to do that. And then opening the artery is critical because without perfusion, we have no chance. So it's a tough situation, but it's one that I think the young practitioners need to grasp hold of. And I think as years go by, we'll find even more efficient ways to deal with it. But it's our toughest problem middle of the night. So I thank you both, Salvatore and Ahmad. Appreciate you visiting with us today.
Thank you.
Thank you.